Dear colleagues, good morning. I regret that I'm not able to be with you today. The moment that you are watching this video, I'm flying back to Greece from the European Stroke Organization conference in Lyon. So unfortunately, I'm not able to be with you there. In the next few minutes, we're going to discuss about a 67-year-old lady with previous hypertension who had a brain CT because of some irrelevant cause, for example, frequent headaches, which showed chronic signs of small vessel disease. And we're going to discuss whether we should treat this lady with antiplatelet treatment or not. And this is not something rare that you see in clinical practice. Virtually any elderly patient that you will ask for a CT, for a brain CT or a brain MRI, you will find something which is described as small vessel disease, or there are several terms that you can describe these lesions. They may be called small vessel disease, small artery disease, leukoencephalopathy, leukoareosis, chronic ischemic microangiopathy. There are several terms that they are used by radiologists and clinicians to describe these lesions. So how do they look like? This is how it looks like. This is a brain CT where you see those hypodense, those black-looking areas in the periventricular spaces, as you see here with the arrows. But if you have a brain MRI, you will see the same lesions, but that time you will see them white and again in the periventricular space, and this is what is called leukoencephalopathy and leukoareosis. It's not called leuko because it has white color on MRI. It is called leuko because it happens in the white matter of the brain. And what is the mechanism behind this small vessel disease or small artery disease? Actually, these are the small arteries that we're discussing about. These are actually arterioles, very narrow arterioles, which, as you see, they go out almost perpendicular from the mother artery, which is, for example, here the middle cerebral artery, or for example, the basilar artery and the posterior circulation. So you see that these are perpendicular arterioles which go through the brain parenchyma and reach the deeper areas of the brain, the periventricular spaces, and this is where they supply blood to these areas. And it is a disease of these small arterioles, these small narrow arterioles, which causes the images that we saw in the previous slide. And this is how it looks like, as we described, white lesions in the white matter of the brain, in the deep structures of the brain, which may be confluent, like you see here, for example, or they may be something like that, which at some other example we would call it as lacunar stroke. And what is the pathophysiologic basis of this disease? It's something that we call lipohyalinosis. This is the cross-section of a small arteriole, and this is how the wall of this small arteriole got thicker and thicker, and now it's too thick, and as a consequence, the lumen of this small arteriole gets more and more narrow. You see here the small blood constituents, so you understand how narrow this small arteriole became, and this is how you see it in post-mortem. And at some point there may be also amorphous material within the lumen of this small arteriole. So this narrowing of this narrowing of these small arterioles, they have the consequence of allowing less and less blood through these arterioles, and as a result, the areas of the brain which depend on these arterioles to be supplied with blood, they receive less blood, and as a result, we have these chronic ischemic lesions in these deep lesions of the brain. And what are the three main causes which cause these small arterioles to become more and more narrow? First of all, it is the age of the patient. The older a patient, the older a person, the more severe is the small artery disease of the patient. But beyond age, there are two other important causes, and these are arterial hypertension and diabetes mellitus. Arterial hypertension and diabetes mellitus are two very important, very significant causes of small artery disease. But we have to understand that this small artery disease is not related only to the brain. It's not located only in the brain. The small circulation, the small artery circulation is throughout our circular bed, and you can find similar lesions, that is small artery disease, also, for example, in the retina and also in the kidney. And this is what we know as arterial retinopathy and arterial nephropathy, and hypertensive retinopathy and hypertensive nephropathy, and also diabetic nephropathy and diabetic retinopathy. These are just two other manifestations of the small vessel disease. So it is a disease throughout the body, which has manifestations mainly in the brain, in the retina of the patient, and in the kidneys of the patient. And this is the manifestation that we have from the brain, as we discussed about this 67-year-old lady who had this imaging. So now the question comes, these are caused by ischemia. This is not of thrombotic origin, but it is due to structural ischemia, due to narrowing of these vessels. So the question arises, should we prescribe antiplatelet, for example, aspirin, for this lady to protect her from a subsequent stroke? So actually we discuss about aspirin for primary prevention, because this lady didn't have any event from the brain, for example, stroke or TIA. So do we have any evidence to support our choice? Yes, we have a lot of high quality evidence, and these are several trials going back from 1988 through a few years ago. So this is a nice graph which summarizes all these trials since 1988, and you see that the trials which are on the upper panel, on the upper part of the graph, these are trials where efficacy was not proven. That is, these were negative trials of aspirin for primary prevention. On the contrary, those 4 trials, the HOT trial, the ECLAP, the ECLIPSE, and the ASCENT trial, which are on the lower part of the graph, these are trials where efficacy was proven. So you see that most of the trials of aspirin for primary prevention, they were negative in terms of efficacy. Now, with regard to the color, you see that some trials, they have red color, for example, the UKTIA, the PHS, the PPP trial, and others. On the contrary, some of those, they have blue color, like, for example, the BTT trial. And what does it stand for? The red colored trials, these are the trials where higher bleeding risk was shown. So as you see, among those 4 trials which showed some efficacy, 2 of them showed also higher bleeding risk. So actually, if you conclude, you see that among all those trials of aspirin for primary prevention, there were only 2, the ECLAP trial and the ECLIPSE trial, which showed efficacy of aspirin without increased bleeding risk. So actually, you see that most of the evidence is against aspirin for primary prevention coming from all the other trials. Perhaps the 3 most important trials are those 3, the ARRIVE trial, the ASCENT trial, and the ASPRI trial, all of them published in 4 years ago in 2018, 2 of them at the New England and 1 at the Lancet. Now, the population in these 3 trials was different. In the ARRIVE trial, it was patients with moderate cardiovascular risk. In the ASCENT trial, there were diabetic patients, and the ASPRI trial, there were elderly patients. And these are the graphs showing the bleeding risk in these trials. And you see that in all 3 trials, aspirin was associated with a higher bleeding risk compared to placebo. Now, if you have a look again at those 3 trials, the ARRIVE with the purple color, the ASCENT trial, and the ASPRI trial, in terms of efficacy and in terms of safety, these numbers here, they show the number needed to treat for each of those outcomes. And you see that with the asterisk, this was the only efficacy outcome that was statistically significant. So among all efficacy outcomes in those 3 trials, only in ASCENT there was some effect, some beneficial effect with a number needed to treat of 91 to prevent 1 primary endpoint. All other outcomes, efficacy outcomes, were negative. On the other hand, with regard to safety outcomes, you see that especially for the outcome of gastrointestinal bleeding, there was significant risk, high risk with aspirin, with an upper need to treat around 200. So we see again with another graph that those 3 important trials didn't show any strong beneficial effect in favor of aspirin. On the other hand, they showed this moderate effect of harm with aspirin, especially in terms of gastrointestinal bleeding. And this is a nice review of all related trials of aspirin for primary prevention and several outcomes here, all-cause mortality, MACE, cardiovascular mortality, etc. So what does this meta-analysis show? Again, not really good, not really optimistic things about aspirin for primary prevention. You see that aspirin does not reduce all-cause mortality, makes little to no difference in MACE, may not reduce CV mortality, may not reduce myocardial infarction risk, may not reduce stroke, may result in an increase in major bleeding, likely results in an increase in major GI bleeding, may result in an increase in intracranial bleeding. Now, there are some small beneficial effects, particularly aspirin likely results in a slight reduction in all revascularization procedures, may result in a slight reduction in coronary revascularization, and may result in a slight reduction in amputation. So you see there are some small beneficial effects, but these are in not in so hard outcomes. Mainly they are related to procedures like revascularization, coronary revascularization, and amputation. Now, there are some consensus with regard to aspirin for primary prevention. This was until recently the main one published in Circulation 4 years ago, where 4 criteria were suggested by the authors. So 4 questions that we had to ask: is our patient between 40 and 70? Does the patient have a high burden of cardiovascular risk factors based on clinical judgment? Is the bleeding risk low? Is the patient informed of the null to modest expected benefit of aspirin in addition to the definitive higher bleeding risk? Does the patient favor atherosclerotic disease prevention over bleeding avoidance? So if the answer to all of these questions is yes, then low dose aspirin can be considered in a shared decision-making process in selected patients. So you see really hesitating to give strong suggestion in patients that have a yes to all those 5 criteria. If there's even a single no, then you shouldn't give aspirin for primary prevention. This might look a bit complicated, and recently it became much more simple by the US Preventive Services Task Force. This was a nice recommendation statement published a few days ago at the JAMA, where it is clear that for adults who are 60 years of age or older, the Preventive Task Force recommends against initiating low-dose aspirin use for the primary prevention. Now, with regard to patients who are younger than 6, that is between 40 and 59, then evidence indicates that the net benefit of aspirin use in this group is small, and patients who are not at increased risk for bleeding and are willing to take low-dose aspirin daily are more likely to benefit. But again, the decision should be an individual one. So it becomes clear that for patients who are older than 6, then forget about aspirin for primary prevention. For younger patients, you may consider it, but again, it should be clear that the benefit, the expected benefit, is really small. So going back to Our Lady, and this is my last slide, this 67-year-old hypertensive lady who had a brain CT with chronic signs of small vessel disease, but without any stroke, without any TIA. The question is, should I treat with antiplatelets? The answer is clear. No, we have high quality evidence nowadays to know that the answer is no, we shouldn't treat with antiplatelets. This is the message that I wanted to convey. Thank you very much, and I wish you a very enjoyable Congress. Thank you very much.